Hola, buenos días a todos y a todas. ¿Algún voluntario para la primera fila? Vale, me lo temía. Bueno, buenos días a todas y a todos. En primer lugar quería presentarme. Soy Daniel Farrés, responsable del negocio de veterinaria de Braun España, y en nombre de todo el equipo de Braun VetCare os queríamos dar la bienvenida a Braun.
Desde 1839, Braun asume el reto de cuidar y proteger la salud de las personas de todo el mundo. Una tarea encomiable, pero también de una enorme responsabilidad. Hoy en día, después de casi 2 siglos, Braun es un grupo multinacional que cuenta con más de 60.000 colaboradores y está presente en 64 países. Para llevar a cabo su misión, Braun colabora activamente con sus socios y clientes para entender sus necesidades reales y desarrollar soluciones eficientes que mejoren la salud y el bienestar de todos nosotros y también de los animales. Y es que los conocimientos y experiencia de la compañía, acumulados en sus 180 años de historia, se transfieren al campo veterinario, convirtiendo a Braun VetCare en un referente en el sector y consolidando la filosofía del sharing expertise, que nos permite mejorar continuamente las prestaciones de productos como las soluciones de fluidoterapia y las suturas quirúrgicas. Esta pasión se traslada a la medicina y cirugía veterinarias en toda su amplitud y diversidad, tanto de especies animales como de áreas terapéuticas, desde las mascotas de casa a los animales exóticos y a la producción animal. La medicina veterinaria, que tiene como objetivo prevenir y curar las enfermedades de los animales, no deja de avanzar. Y en Braun VetCare nos esforzamos para que estos progresos y avances lleguen lo antes posible a los pacientes. En este sentido, en Braun VetCare invertimos todos nuestros recursos en facilitar, además de los productos y servicios más avanzados, la capacitación y formación continua necesaria para que el clínico pueda realizar diagnósticos precisos, cirugías exitosas y tratamientos eficaces. A día de hoy, la disponibilidad de terapias punteras en centros de referencia facilita que los animales domésticos ya puedan optar a cirugías cardíacas, intervenciones intracraneales, sesiones de diálisis o tratamientos de quimioterapia casi al mismo nivel al que optan sus propietarios. Esta alta especialización coexiste con la atención veterinaria de proximidad, tan necesaria en el contexto global de la medicina veterinaria. En Braun VetCare queremos ofrecer soluciones para todos ellos, dando acceso a la mejor tecnología, innovaciones y servicios a todos los niveles. Y es que desde 1839 hasta hoy, muchas cosas han cambiado. Los recursos son mayores y también el conocimiento, pero nuestro reto sigue siendo el mismo: cuidar y proteger la salud y el bienestar de los que más nos importan.
Bueno, visto esto, os tengo que decir que estamos muy felices, ¿no? Y creo que hablo en nombre de todos mis compañeros, de podernos reunir aquí hoy, después de 3 años del último simposium y 2 cancelaciones debido a la pandemia. Pues hablo en nombre de todos, estamos muy contentos de estar juntos para abordar durante estos 2 días una temática emergente, como es el intervencionismo y cardiología, ¿no? Y de un interés creciente, creemos, común para todos, ¿no? Y eso lo demuestra el hecho de esta sala llena. Y además, ¿no? Adicionalmente, contamos para esto con la participación de 2 ponentes de máximo nivel, como son el doctor Hulk y la doctora Mois, que nos acompañarán durante estos 2 días en un programa creo que es muy enriquecedor y que ahora pues mi compañera Mireia Riba os presentará con detalle. Gracias.
Hola, ¿me oís bien? para comentaros el programa tenéis encima de la mesa y ahora Dani lo va a proyectar. Hoy tenemos, el simposio está compuesto por 2 días. Como ya sabéis, hoy son las jornadas de intervencionismo con Dr. William Kolb y mañana con Dr. Moyes. Entonces, las jornadas de hoy tendréis 6 ponencias, también habrá un poco de tiempo para hacer un café, la comida es fuera, en la cantina. Y luego, a partir de las 4, paralelamente a las ponencias, hay una sesión de hands-on que es simplemente en otra habitación que tenemos al lado, el showroom, pondremos dispositivos de intervencionismo de Dextronics, productos de Vascular Systems. Nos podéis hacer preguntas, podéis tocarlos, podemos hablar un poco de los productos, pero si hoy queréis realmente ver todas las jornadas de intervencionismo, os recomiendo que os quedéis hoy y mañana podéis ir. Son igual las 2, ¿sí? Y luego a partir de las 8 de la tarde tenemos una cena especial en Can Ferran que está a 5 minutos, ¿vale? Los que queráis venir, pues seréis bienvenidos. Entonces, hoy tenemos el placer de tener a Dr. William Kolb. Thanks, Dr. Kolb, for coming. He's the chief of the Soft Tissues Department in USC Davis in California. He's a diplomate, a board-certified diplomate of the American College of the Veterinary Surgeons. His specialties are soft tissues, but mainly surgical oncology and interventional techniques. So today you'll have the opportunity to enjoy his lectures, and I hope that you will make the most of it. Thanks, Dr. Kolb. An applause for him.
Well, thank you, everyone. It's so great to be here today. I appreciate the opportunity. I love Spain. I've been here. I'm lucky. I've gotten to be here a lot of times, and so it's been a while. It's been since before the pandemic. Before the pandemic, I was coming to Spain a couple times a year, mostly to Barcelona. So it's great to be back. I haven't been back since before the pandemic. So thanks for having me. It's great to be here. Be here together for the whole day. So I feel like we should be as comfortable as we can. So usually when I talk, I am happy to be interrupted at any point and throw out questions. If you see something up there that you have a case and you're like, oh, let's talk about that, let's do that. I'm happy to talk more about that, hear about your experiences, and try to hit the areas that are of interest to you. So please feel free to interrupt at any point and let me know if there's anything I can explain better or talk about in more detail. So in 6 sessions today, we're going to cover a lot of interventional radiology as far as its impact in veterinary medicine right now. And we'll start with the principles just to kind of run through some things. The principles could take the whole day and we could kind of go to that route, but we'll focus more on just trying to hit some of the major things this morning and then talk about some very specific diseases throughout the day. And we're going to hit kind of a lot of different things and talk about a lot of different procedures, and I hope that even for those of you out there that aren't regularly doing interventional procedures, that hopefully there'll be some things that you see where you're like, oh, those are things that we can incorporate into our practice sooner than later, because I really think that this is the type of specialty where everyone can do it. I think that that's what's so interesting is that in the U.S., anybody that has any kind of different specialty is doing IR, and I think the same can be said anywhere in the world. So I'm excited to talk to you more about those things today. All right, any questions before we start? All right, let's get going. So to start today, we'll talk about just giving some background information on IR. We'll give a little bit of an overview of just what interventional radiology is, talking more about what IR is, thinking about the imaging modalities that we use for these different techniques, looking at some of the unique instrumentation and principles, the approaches, and then just a quick overview of the veterinary applications. And so when I think about interventional radiology, I think about 3 major components to it. I think specifically that we use image guidance, and so that's the biggest one because the first one leads into the second one. We need to be able to use image guidance in order to try to do things in a more minimally invasive fashion. And so it's not that we are trying to do things like they do in human medicine. It's that we are trying to offer better options, more options, things that improve quality of life for our patients, things that potentially through improving quality of life, we can also hopefully improve the longevity of life. So not just making patients live longer, because you'll see some of these techniques today could definitely just help patients to live longer, but through living longer, also hopefully helping them to live a better quality of life during that time. And so that's why we have a big focus on minimally invasive procedures. And so as part of that, image guidance is a very, very important component. And so in veterinary medicine, a lot of that comes down to fluoroscopy, where I would say of the IR procedures that I perform regularly, 95% of them involve fluoroscopy. We do a decent amount of ultrasound procedures, and that's something I think that we can see progress over the years a little bit. Because I think that as veterinarians, unless you have a specific focus on ultrasound or you get trained in ultrasound, you oftentimes don't learn how to do ultrasound. And so I think that that's something that if you're interested in these types of procedures, you can start to learn that as well. That's something that I've tried to take up over the last 5 or 10 years and try to learn a little bit more, because I did not have any previous training in that. But it also involves thinking about how you look at your CTs, so your CT angiographies, your magnetic resonance, your MR angiographies, also thinking about how we look at those things. Because we all, again, look at those different imaging modalities and we use them as a diagnostic tool, or we use them in preparation for doing procedures. But when you're starting to think about doing them from the IR standpoint, you have a little bit of a different take on it. You start to think about more of the vascular anatomy, how that might impact how you can get to a different location. What type of luminal obstruction are you looking at, and where is that obstruction at? How long is it? How bad does it look? And so I think you start to use those different techniques, those other imaging modalities better, as well as you start to do more IR. And then when we think about the minimally invasive aspect, as much as possible, we try to use a natural orifice, and so we'll talk a lot about that today. When we're talking about doing tracheal procedures, urethral procedures, we're always trying to use a natural orifice whenever possible. Again, that's one of the really interesting and cool things about IR and vet med, is that we're able to do a lot of these procedures now incisionless and avoid having to do incisions when we historically have had to do incisions, which is obviously something that's going to lead to hopefully improving the outcomes for our patients. And lastly, we want to have this goal of either acquiring a diagnosis or providing some sort of treatment. And so just like we do every day with our other techniques, this is something that IR has the same kind of purpose for. Specifically, I mentioned what is IO. Interventional oncology is a subspecialty of IR. And so it's basically the whole concept of IR, but with the specific goal of treating oncologic cases or neoplasia. And so a lot of what we do in veterinary med is treating neoplastic disease. And so when we look at IO and the different things that we have available, we think about these three major areas that interventional oncology can be utilized. Most of what we do is going to be palliative. And so, thank you. Are you just going to click down these lights in the front maybe? He what? Oh, he left. Okay, thank you. And so most of what we do for, Mariah, do you mind just turning the front lights just to help, because I'm gonna have a lot of fluoro. Thanks. Most of what we do with the interventional techniques is palliative. And so when you think about the options, a lot of where interventional radiology started in vet med was with the stenting. And so stenting in general has a goal of palliating an obstruction of some sort. And so it's not a long-term, well, I don't want to put everybody to sleep. Yeah, maybe just do just these go? If not, don't worry about it. Just so people can see. Unless can you all see? Okay, we're going to have a lot of fluoro, so yeah, that's fine. That's great. Thank you. Sorry. And so palliation is the big thing. So when you think about the options for what we're going to use stenting for, a lot of them are going to be palliative. And so that doesn't mean palliative has this kind of negative connotation that you're doing something that maybe you shouldn't be doing. But the reality is palliation can actually benefit our patients a lot and actually provide them with a much better outcome. The primary treatment options, especially with interventional oncology, are still pretty limited. When we think about primary treatment options, we're saying, what interventional oncology technique are we going to use where that's going to be the main thing that we do to treat it? And so there are some things that are starting to come about. So we think about specifically embolizations. And so we're not going to talk about tumor embolizations today, but one of the areas where there's been a lot of expansion is giving an agent directly to a tumor's blood supply so that you can cut off the blood supply to a tumor, essentially starving the tumor of its nutrition, taking away its blood supply and killing it. And so that's had a big growth in the last 4 or 5 years, especially in the treatment of liver tumors that are non-surgical and prostate tumors. And so as a primary treatment, that's one area that interventional oncology could really, really expand as a primary treatment, as the main treatment. I think one of the cool areas to see more expansion is in the area of adjuvant therapy. So adding in interventional oncology techniques on top of other techniques that we're using for cancer treatment. So as an example, if we're giving chemotherapy to treat a lower urinary tract tumor, but we're also using a stent as well to open it up. You know, when we think about lower urinary tract tumors, usually these dogs are presenting and cats are presenting obstructed or with some lower urinary tract signs. And so they oftentimes don't have a lot of other systemic disease. Most of them are not metastatic at the time that they actually present. And so if you stent them, open up their urethra, you can make them feel better, you can relieve the immediate issue that they're having, and then you can follow up with chemotherapy. And so the combination of those two things acts together in order to be an adjuvant therapy. And so it's a nice option when thinking about that. So as far as the imaging modalities, most of the time we're talking about a C-arm. And so here's an example, maybe, of a C-arm. And so C-arm just is one. This is our old cardiology suite, which is expanded since then, but it gives you an idea of kind of how these would fit into a room. And then if you haven't seen a C-arm before, this is just kind of the general motion of a C-arm. It can go in all different directions. And so as long as you have a fluoroscopy compatible table, you'll be able to kind of rotate this around and move it around the patient, which is a really nice option to have to be able to see different images. And so this is a really usable mobile unit that's quite good and can do the vast majority of the procedures. But you also have this option too, where you can kind of outfit a whole room to be set up like this. And so this is a bit more of an advanced setup. So this is a floor mounted or ceiling mounted unit. This wall is really, this is not my wall. This wall is really nice. It's like a touch screen, and you can bring up all the images, like as big as this whole wall here. So there's some really advanced ways that you can set up these rooms as well. And so it's nice to think about those options and think about kind of what the future could potentially hold in different ways. Ultrasound, like I said, is really, really useful. Here's just an example of ultrasounding. This is a case we'll see later today. This is just ultrasounding a distal limb arteriovenous malformation. And so I'm sure all of you can kind of see that ultrasound looks very abnormal. There's a lot of activity going on there. You're seeing a big mixing of the different types of blood supply there, where you're seeing the arterial and the venous blood supply. And so ultrasound is a great staging diagnostic in trying to help determine whether a certain situation is going on, but it's also really useful for doing procedures. And I think one of the areas that we need to expand into is using ultrasound for getting access more, which is something that we're starting to do more. And like I said, CTA, MRA, very, very helpful. In particular, we're doing CTs of all of our cases, all of our vascular cases preoperatively as a map, and then also as a way of trying to determine what anomalies are there. So before doing our intrahepatic shunts, if we're going to do a coil embolization or if we're doing tumor embolizations, we're usually CTing all of those cases beforehand. All right, so let's talk about some of the instrumentation, because this is unique to IR. This is the one that's not unique. This is one that we all feel comfortable with. We see these every day. The typical access needles and catheters. And so the access needles and catheters that we think about most commonly with interventional procedures are going to be an 18 gauge and a 22 gauge IV catheter. And the reason that we select those two most commonly is because those are what the guide wires fit into. When you're doing IR procedures, you feel like your whole life depends on your guide wire. And so what the guide wire is it is the way to select, the way to get into whatever the area is that you need to get into. And so a typical guide wire looks like this. This in particular, this one on the right, is a hydrophilic guide wire, and so this has a coating on the outside that makes it very slippery. So if it's wet, it allows you to get into different locations more easily. And it's a very safe instrument to use. And so when you're choosing a guide wire, you're choosing it because you're trying to pass it into a lumen, pass it into a blood vessel, pass it somewhere that you can get access into, because it lets you get other things there. So it's kind of the means of getting things into where you need to get it into. And so back to thinking about the catheters and things, this is why we choose those different catheter types, is because for an 0.35-inch guide wire, you're going to need an 18-gauge catheter. For an 0.18-inch guide wire, you're going to need a 22-gauge catheter. And the vast majority, 99% of the procedures that we do in vet med currently are using one of those two guide wires. These micro wires, these 0.14-inch micro wires, are most commonly used for the tumor embolizations. And so unless you really got into doing those types of things, it's going to be uncommon that you use those. Those micro wires get very, very small. That's 0.014 inches, so pretty tiny. And so they get very, very small. They're challenging to use. The smaller, you would think sometimes that, oh, I have a challenging obstruction to get past, I'm going to use a smaller guide wire. It's actually harder because you have less pushing power. The smaller the wire is, the more floppy they get, the less easy they are to manipulate. And so these small guide wires are used specifically for getting really small access. And so we'll see those later today when we talk about the arteriovenous malformations. Different guide wires come with different lengths, and so in vet med, most of ours fall into that 180, 150 centimeter long range, and so as you can imagine, the majority of these products are designed for humans, or they all came out with the concept of humans, and so at some point it was established that those were the ideal lengths for humans, but they happen to work pretty well for us too. And so we use these 50 centimeter ureteral stents, or 50 centimeter ureteral guide wires for ureteral stents in cats specifically. And then in some cases we can use the 150 centimeter long guide wires for smaller patients, so either putting a urethral stent in a female dog or potentially putting tracheal stents in. But most of what we use is going to be the 180 centimeter long guide wire, which most of the equipment will pass over. And what you're thinking about is that if you pass a guide wire into your patient, you're thinking about, I need to get that guide wire where it needs to go, but then I need to have enough of the wire outside the patient that I can pass over an instrument. And so if you have a catheter that you're passing in, you don't want to be passing a catheter in and not have access to the guide wire. So if you have your guide wire in your patient and you're passing your catheter and you realize there's no guide wire outside of the patient, now you don't have control of that guide wire anymore. And so when you're thinking about length, that's what you're thinking about. You're thinking about how much length of guide wire do I need to be able to get into the patient, and then also have sufficient length outside of the patient when I'm putting the catheter over top of that. The 260 length, that's a really, really long guide wire. And so it's called an exchange length because the idea here is that it needs to be long enough that you can exchange very, very long pieces of equipment. And so for us, there's really two main applications so far for the 260. One is doing percutaneous ureteral stenting in dogs, where you come in through the kidney and then down and out through the urethra so that you have guide wire both on the kidney side and on the urethral side. And then you need a lot of guide wire in both of those situations. The other one is that we do embolization of nasal tumors, so we'll take down the blood supply to the nasal tumors. And so if you have a big dog, you're coming all the way from the femoral artery all the way up into a nasal tumor, so you need quite a long catheter for that. And guide wires have different stiffnesses, so you would choose maybe based on what you're going to do. Most of the stiffnesses that we choose is just what's called a standard stiffness, and so that's most common. This is a pretty simple one, but this is just looking at one of the bowls that we use, and you would think, oh, this bowl, why would I need a special bowl? Well, it's actually kind of a pain to keep these wires managed. These wires are very slippery again, and so sometimes you can't even tell whether you're manipulating them. And so having one of these bowls that specifically prevents them from falling out is really, really useful. And so this is just another little, just an example of something that's been adapted specifically for interventional procedures. I like to talk a lot about sheaths because sheaths are something that, you know, from day one, even if you're not going to do a ton of IR procedures, sheaths can be very, very helpful for different things. And so this is a sheath. And so a sheath has historically been designed for doing vascular procedures to get you vascular access. And the reason it's designed that way is because when you look at the sheath, I'm not quite sure why this isn't working, but it like goes everywhere but on the screen. It's what? Oh, it doesn't work. Okay, good to know. I'll let it down. Okay, I'll just hold it for, that's my safety valve. No, so the sheath is really good because the sheath has in the top where the red part is, there's a hemostatic valve. And so essentially that hemostatic valve prevents things from leaking out. So in the vascular system, that's important. You put that into the jugular vein, you're not going to have continuous bleeding. Even more important when it's in the arterial system because it's going to prevent them from bleeding. But when we use it in other places too, so we'll use it to get access into the chest. We'll place it for urethral stents, and so it prevents urine from coming out. It's a really, really nice option to have. So you might see some different indications today for sheaths that you might want to consider. What's cool about sheaths is that they're sized for what they accept. So they're the only instrument that when you look at their size, it's the size of what can be passed into a sheath. And so what I mean by that is that a 6 French sheath can accept 6 French of equipment. If you talk about a 6 French catheter, 6 French catheter has an outer diameter of 6 French. A 6 French sheath has an inner diameter of 6 French. And so it's important to think about when you're doing these different procedures because you think about what's the largest piece of equipment that I'm going to use today, and then that piece of equipment, I need to place a sheath that is at least that size. And so for some of these procedures, that's a really, really important thing to think about, mostly for the vascular procedures, but it also plays a role in some of these other things when you want to choose the right sheath size for placing a urethral stent. All these sheaths come with a dilator, and so the dilator tapers down to the wire. And so that allows you to safely pass a sheath into a location because you have this blue part that's going to taper down to the wire. And so there's going to be a nice transition between that blue, the tip of that blue bit, and the wire. And then the sheath tapers down to the dilator. So it all works together. When you're doing the actual procedures, you're going to take the blue part out. You're going to take the dilator out because that's where you're going to get the room inside the sheath to be able to perform your procedure. Catheters, so these are not the typical catheters. These are not the IV catheters, the red rubber catheters, the things that we think about when it comes to that. These are more specialized, and most of these have an angiographic purpose, but it doesn't mean we can't still use them in different interventional procedures. They're usually categorized by their tip, and so a straight tip, you'll see this one a lot today. This is a marker catheter here on the far left. It has these little marks. And so it gives you an idea when it's on a fluoro image about how much distance there is between those two marks. So you can use this to calibrate. You can put that in to an organ close by, whatever the organ is that you're interested in. Let's say you want to measure the urethra, you can place this in the colon so that it's close by, and you can use that as an actual marker so that you know exactly what it is that you're trying to measure size-wise. There's pigtail catheters, there's these big hook catheters here, the third one over. The hook catheters are mostly for vascular procedures, and then these angled catheters, which we do a lot of different angiographic studies as well as doing contrast studies. All right, let's talk about stents. And so stents are something that has this kind of general term, and lots of times, at least in my mind, when I think about stents, I kind of think about those cage-like stents that have the metal aspect to them, but stent really can be any kind of cylindrical device that you use to try to keep a lumen open. So whether it's a lumen that's been obstructed from tumor or benign stricture, or you've created an anastomosis there, your goal of placing a stent is to try to keep that lumen open. And so obviously this is common in human medicine. Most commonly it's done for cardiac diseases, we know, for placing them for coronary disease. And so interestingly in vet med it's kind of the opposite. We do place some vascular stents. Obviously we don't place hardly any in the heart, but it's something where we do a lot of non-cardiac stenting in vet med. And so that's something where there's been a lot of advances over the last 20 years and something that we'll talk a lot about today. In humans, the most common outside the heart application is for ureteral obstructions, so stone disease, where there's stents that are placed usually percutaneously in order to try to reestablish urine flow going from the kidney down into the bladder. And I would say this is one of the areas that's really progressively increasing in vet med. And if it's your interest to kind of get into IR, starting with stenting is usually a really good place to go because there's some really most common applications having to do with stents. And so as I said, there's a lot of different materials for stents. Historically, they were made out of stainless steel. Now the majority of stents are made out of nitinol. And so nitinol is a nickel-titanium alloy, and so it's this combination nickel-titanium developed at the Naval Ordnance Laboratory. That's where the name kind of comes from, or it does come from. And so nitinol is an option for the vast majority of our stents. And so most of the stents that we place are made out of nitinol. It's very well tolerated. It's something that our patients tend to have a very, very high tolerance of. You can also get stents that are temporary. So you get stents that are made out of PDS suture, which I think is really cool, that you can make a stent out of a suture, but it can still be firm enough that it can hold open obstruction. It can keep a lumen from being compressed over time. And so that's something that you would place if you want to place a stent and have it not stay forever. So most common application in vet med right now would be for esophageal strictures. And so the esophagus is just a territory that doesn't tolerate stents that great. Dogs can have pretty significant reactions intraesophageally from having a stent in place. And so it's nice to potentially place a stent, have it last for 2 or 3 months, and then see if that was sufficient enough to keep a stricture open. And so that's a nice option, and something usually when we're talking about esophageal stenting in veterinary patients, we're usually starting with placing PDS stents. Yeah? Yes, it's a good question. So the question is it really floppy? Amazingly, it's not. I don't know the process by which they don't do that, but if you push on it, it's coming right back out. It's popping right back out into position. So it's not as strong as a metallic stent or an alloy stent, but it's quite strong. Yeah, so like as an example, one of the non-esophageal applications we did, we placed one into a horse. And so the reason we chose it is because we never placed a horse urethral stent before. So this was for a horse that had a perineal urethrostomy for a stone. It was a very valuable, fancy horse in the U.S., so it's important that it was able to continue to breed. And so they wanted to maintain urethral patency. And so we placed it, and even in that situation, like a horse urethral stricture, which is pretty strong, it was able to hold it open. Yeah, so they're stronger than you'd think. And they usually tend to be big. They have to be of a certain size to actually make them stiff like that. Yeah. Stents can be simple things. They can be made out of polyurethane. Ureteral stents are an example of that. Red rubber, latex stents, I'll talk about during nasopharyngeal stenosis today. A simple way to kind of handle nasopharyngeal stenoses is just using a red rubber stent. And so all of these things, kind of thinking outside the box, any kind of tube that you put in, sometimes I'll be in situations where I don't have the exact specific stent that I'll use, so I'll just figure out a catheter that will kind of place in that situation, and that'll act as a stent in that scenario. So it's always something to just be creative and keep your mind open. Stents, these type of metallic stents can be covered or uncovered. And so the uncovered stents means that there's holes in the stent that you can see there in between the wires, and those are open. And so those openings in the stent would allow, let's say, blood to go through. So if you're placing a stent for a coil embolization of a shunt, you could still get blood to easily pass through that. And you might think, or I might think, that if you place a stent for a tumor, you wouldn't want to place one of these opened stents, but actually the chances of strictures growing through stents is actually greater than tumors growing through. So it's kind of an interesting, I think it's interesting because I would not have expected the strictures to be more capable of potentially growing through a stent than a tumor, but that seems to be the case. So the time when we most commonly use these covered stents, which are the ones on the bottom, they have a covering in them that's made of some sort of film. It's a material, it's like Teflon or Dacron, something that's covered in between each of the cells to actually close down those cells. The time when we most commonly use those are for benign strictures that we see in different locations. Stents can be delivered in different ways. They can be delivered as a self-expanding stent or as a balloon expandable stent. One of the interesting, these metallic stents specifically, one of the interesting things about nitinol is that it's called a shape memory metal. What that means is that when it's at a very, very cold temperature, it's compressible. And so you can kind of form it into whatever shape you want to. So you take nitinol, you cool it, you can compress it down, and you can form it into a different shape. But then when it comes to body temperature or room temperature, it's going to expand. It's going to go into its expanded position. And so a self-expanding stent can be placed onto a delivery system. You can see here how the stent is kind of compressed down onto this orange inner component here and then covered with the sheath over top of it. So it can be compressed down into that. And so that means you can deliver it or place it in a small area. You can place it in a very low French diameter, but then when it expands out, it gets much, much wider. So for instance, a tracheal stent might be 10 French on its delivery system when you're placing it. So what's that, 3.3 millimeters about in diameter, but then you place it and it can be 14, 16 millimeters. So, up into the 30, 40, 50 range of French. So it gets quite a bit larger once you're actually placing it and you see it expand out. You can also get balloon expandable stents, which are stents that are preloaded onto a balloon. And so what's nice about these is that you can very specifically place them. You can target them in a location where you can very specifically drop them so that they they're unlikely to move. You also have the benefit that as you balloon dilate, that it's going to open up the stricture. And essentially you're ballooning as you fill the balloon and open it up, the stent expands out, contacts the wall of the tissue that you're in, and then it's going to stay in position there because you've had the combination of ballooning open the stricture, but then also deploying the stent. And so they're nice from the ease of placement standpoint that you're going to be very, very specific where you're going to target them. The downside of balloon expandable stents is that if you compress them hard enough, you can really collapse them down and they're not going to come back. As opposed to the self-expanding stents, which kind of have this continual radial force that they're generating, they're continually pushing out. These balloon expandable stents eventually are going to give as you start to compress them. One other aspect to look into is also how the stents are made and what they're made out of. And so there's mesh stents or woven stents, and then there's laser cut stents. And so the top left is an example of a tracheal stent, and so this is a mesh stent. What's interesting about this is that it's made out of a single piece of wire. And so you take a piece of wire and you weave it back and forth essentially and create this stent. And so as you compress on these, they tend to foreshorten, which means that they're long when they're on the delivery system, but as they start to open up, they shorten down. Because as a single piece of wire, if you push on them, they're going to lengthen out. But then when you take that pressure off, they're going to go they're going to go more into their regular diameter, but they're also going to lose some length. As opposed to the laser cut stents are generated from a single piece of nitinol or whatever the material is, and then a laser is used to actually cut out the holes in it. And so if you push on a laser cut stent, you're going to see that they don't change their length at all. And so they both have advantages and disadvantages. Of the mesh stents, the advantage is that they're reconstrainable on the delivery system. So you have them on the delivery system, you're starting to deploy it, you're 3/4 of the way out and you don't like where it's positioned, you can reconstrain them and replace it. The laser cut stents are not reconstrainable, but they're much more specific where you're going to be able to place them. You can imagine if you have one of these woven stents that shortens as you deploy it, it's a little bit harder to kind of figure out the length that you're going to need in that particular situation. So we'll talk a little bit about that when we talk about tracheal stents. Here's an example of that, just compressing one location here. You can see as you compress that the stent actually lengthens. And so when you look at these stents on their delivery system, they're going to look much, much longer than they are when they're actually placed. I'm going to come back to that one when we get to tracheas. Here's just another look at that, which we'll look at in the tracheas as well. So this is a stent on its delivery system, and you can see how it's all compressed there prior to placement, and that red line is going to mark how long this particular stent is, and then after deployment, you can see same stent, same patient, that you've lost a couple centimeters of length on the length of that stent. As opposed to the laser cut, as you compress them, no change in their length. And so again, the advantage is it's much easier to place and position where they need to place them. The disadvantage is that you can't actually reconstrain those. And this is here, again, with the urethral stent loaded on the delivery system in the urethra here, with the line to mark its length, and it's the same length after it's actually placed. So differences in the types of stents and helps you to kind of choose what you might choose for a particular situation. Here's the delivery of a balloon expandable stent. And so this is for a nasopharyngeal stenosis. And so where we are here is we have a scope that's coming up behind the soft palate. So it's a flexible scope coming into the mouth and looking up behind the top of the soft palate, looking up towards the nasopharynx. And so we have a nasopharyngeal stricture here. Here's the end of the balloon, and you'll see that as the balloon is expanded, the stent on top of the balloon is going to go out with the balloon right there on the edge. That's the stent there. and it's going to stay up and stay in contact and directly up against the obstruction that's there. All right, any questions about stents before we move on? All right. So other instrumentation, there's 4 major categories of embolics that we use, and so it kind of depends again on what your purpose is. For tumor embolization, we most commonly use something that's called particles or beads, something that has the potential to allow blood flow to take it to a certain location so that you can get it down to the distal vasculature so that you can really try to take down the main blood supply going to a tumor. And so this is an example of an embolic. They come usually preloaded in syringes with saline, and so you usually have to remove the saline. They do make embolics now that are radiopaque so that you can actually see them, but historically they were not. And so you'd have to mix them with contrast in order to actually see them being delivered. Coils is another example in the lower left there. Coils are what we most commonly use for portosystemic shunts. And so in dogs, we see a lot of intrahepatic portosystemic shunts. We see them in cats too. But this is what we're tending to place for those types of cases. We place them for arteriovenous malformations as well. Basically, a goal of a coil is to cause a major obstruction at the level that you deploy it. In shunts and things like that, those vessels are big enough where you're going to have some blood flow moving those coils to whatever the location is that you want them to be delivered to. But in diseases such as AV malformations, those are such small vessels that if you put a coil in, it's going to stop right at the location where you deploy it. And so that has pros and cons. The con is that you can't get past it then to do anything beyond it. The pro, though, is that if you want to build up the embolization closer to you, meaning you place a coil and then you might also want to add glue or something on this side of it, that it helps to act as a guard there to prevent things from going beyond. So sometimes we'll place coils in the gastroduodenal artery to prevent us from getting an embolic that actually goes down into the stomach or into the duodenum. And so you'll preemptively place a coil to try to prevent you from accidentally embolizing the blood supply to the stomach or to the intestines. There's some newer liquid embolics. Well, there's the old one, which is just using simply cyanoacrylate. And so very, very simple. It's essentially the stuff, I don't know, do you have crazy glue here? Is that a thing? I don't know, crazy glue. Essentially, it's just the glue that you can buy at any hardware store or any store, at least in the U.S., but essentially it's cyanoacrylate. And so it's the same thing that we use for skin closures when you place skin glue. It's all the same thing. They just make like little slight variations to it to make it really fancy and then way more expensive. And so you can buy crazy glue at this hardware store for $2, or you can buy what's called NBCA, which is an example. The CA stands for cyanoacrylate, which is the exact same thing that's in crazy glue, but it'll cost you $800 for a little bottle of it. So, you know, it's just a way of kind of making a medical level of that type of glue. But honestly, the glue that we tend to use is just some version of like a skin glue oftentimes. And so it's a nice option. It's a little bit, glue's a tough thing to control. The reason glue works is that when you place it into blood, it almost immediately polymerizes. So if you take blood and you inject cyanoacrylate, it's going to form a ball of glue almost immediately upon injection. And so you have to kind of think about when you're using things like glue, and we'll talk about this with the AVMs, how much saline, or not saline because you don't want to use saline, D5W is the solution you mix with it, how much D5W you want to use with it in order to try to make it less viscous so that it might travel further. So glue's a tough thing to use. And so because of that, they've started to make some more fancy versions of liquid embolics. Things like the example here is Onyx. There's another one called PHIL, P-H-I-L, which is another example of a liquid embolic. And these are really, really cool options. They're, again, just super expensive. So getting your hands on those can be challenging sometimes for some of our patients. Historically, there was also some reports of placing balloons as an embolic, so actually going in to wherever you were trying to get to, and they have detachable balloons that you can actually deploy. Nobody's really using those anymore because they don't really work that great. Oftentimes they'll break down or they'll lose some of their elasticity and they won't actually act as an embolic anymore. All right, other things, we use a lot of balloons just for Dilating strictures, so a lot of our urethral strictures, esophageal strictures, nasopharyngeal strictures will pre-dilate with balloons before we put the stent into position because it allows the stent to have to do less work. So if you can pre-dilate an obstruction, you can hopefully open that obstruction up so that your stent can do less work. Torque devices are a really cool thing. If you start doing wire work, it's the simplest little device. Basically, it's this little device that you can just screw onto the end of a wire, but it just gives you really, really fine movement of the wire. So if you're doing any procedures involving wires, this is a nice thing to kind of add to your options for what you can use. And then contrast. Most of our studies involve some sort of a contrast medium. It's been hard to get lately. I don't know if you all are having the same issues we are, but contrast has been in low supply recently, so that's a really important aspect to all these. Very, very obvious. We need it for vascular procedures, but we also need it for our luminal obstructions as well. All right, so let's talk about approaches. We'll first start talking about Seldinger technique. So when I'm talking about approaches, I'm thinking about how do we get to where we need to get in order to do the procedure we need to do. And so Seldinger technique was originally designed for vascular access. And so what I think is so cool about this is actually a picture from the original paper by Seldinger in '53, is that the same exact technique is still done. Slight modifications in that the instrumentation is a little bit different, but the concept is all the same. Essentially, you're getting access into a blood vessel. That's what's being showed up here in A. You're getting access into the blood vessel with a pointy instrument, a catheter, a needle, something that allows you to get access into the blood vessel. And then from there, you're passing a guide wire inside of it. That's this picture B here. You're pulling this needle or catheter off. You're putting some compression down. And then you're sliding something over top of that to maintain your access. So in the majority of our cases, this example is going to be a sheath. So it's basically a way to, as minimally invasively as possible, with the smallest level of incision as possible, getting access to a part of the body that you don't normally have access to. And so the majority of the time, that's for the vascular supply. That being said, we use Seldinger technique everywhere. So we use Seldinger technique to put our chest tubes in. We'll use a catheter to get access into the chest, guide wire in, dilate that, place a chest tube in. We use it to get access into the bladder. Seldinger is a really nice technique. As you start to get comfortable with using it, you start to think of more ways to actually use it for access. So here's a vascular access. This is for a carotid artery approach. So we go into the carotid artery for some of our AVMs and then also for our prostatic embolizations. And so the bottom of the screen is the nose, the tail's going out to the top of the screen here. And so we're just in that region between the trachea and the jugular vein. And so if you go right into that region and you kind of push down at a 45-degree angle, you're going to hit the carotid artery. And so we do a 1 to 2 centimeter dissection in that region. We isolate the carotid artery. We tend to just ligate this. One benefit we have in veterinary patients is that or dogs at least, they don't need the carotid artery. Here's getting access. This is a Seldinger technique directly into the carotid. So it's an 18-gauge IV catheter. Obviously a high pressure system, so we're going to try to get our guide wire up and in position. You're still going to see a decent amount of a blood spurt here. Guide wire in right away. And we're passing that guide wire in to maintain our access. So again, not percutaneous, but still the common Seldinger technique. We've pulled out our catheter now, and then we're following up with our sheath directly in. So this way we have access now with a 5 French sheath, and we can leave that 5 French sheath in place. You can see that dilator's on the inside of the sheath. We take the dilator out, and then we suture that sheath into position. And so this allows us to have access into the arterial system for the whole length of the procedure. And so we'll place that, again, most commonly for prostatic artery embolizations, but any procedure where we need to get access. You can also get into the liver's blood supply from there as well. Femoral artery, very similar. And so patients are in dorsal recumbency. We have their groin exposed, about a 1 centimeter incision. This is a pretty small patient. And so just gently trying to dissect out the femoral artery. You have to be really careful when you're dissecting these out in cats and very small dogs because they can spasm and they can be really, really challenging to get into. So just kind of taking our time here to really expose that. It's a very, very small femoral artery here. And so then taking our suture, wrapping our suture around. Again, we tend to ligate the femoral artery. 22 gauge this time because it's such a small vessel that we're going to get access with a smaller system. And so we tend to use what's called a mini access kit or micropuncture set here. And so we go into our 22 gauge, use this smaller axis with the smaller guide wire. This is going to be, it's called a transition dilator. So we're going to pass this transition dilator over the wire to get us access and open that up further. And that allows you that when you take out the wire and that transition dilator, that you can then pass in a larger wire. So it's a way to get you upsized into the size sheath that you need. So to do these procedures, you're going to have to get in, this is a 4 French sheath, you're going to have to get in at least a 4 French sheath. So even in cats and small dogs that their arteries are usually not large enough to hold those types of sheaths, you have to work your way up and kind of dilate to get your approach to get into them. And so as an example, 2 weeks ago, we did a liver AVM in a cat, had an arteriovenous malformation in the liver, and we had to get that type of access. It's challenging because the cat's femoral artery, a 5 French sheath, is going to maximize that artery. You're really trying to stretch to get that thing in there. Jugular vein, I really like this approach. It's one where you can totally maintain the vessel, so we never ligate the jugular vein. We just use compression because it's a low pressure system. This is an example of a portosystemic shunt approach. And so patients in dorsal recumbency again, so just putting some compression there caudally, access with an 18 gauge IV catheter, have our catheter going in. We can go right with the 035 wire, again, low pressure system, so being careful, but not usually having a ton of blood coming back. Because we're putting such a large sheath in for these procedures, we're putting a 10 to 12 French sheath in. It's a big sheath, it's 4 millimeters or bigger. Because you're putting that big of a hole into the jugular vein, we usually pre-dilate. So that was a dilator coming in just to dilate the hole, and then you can see quite a large sheath coming in here. And so now we're gonna go in with this 11 French sheath and work our way in. That second dilator is then gonna come out. Here's the second dilator coming out of the sheath, making sure we don't lose wire access, and then suturing that in position here. And what's nice again about this is that for these cases we don't do an actual surgical cut down to them because we don't ligate them at the end, we just put some compression on. And then similarly for a small animal jugular vein access, this again we're going to use that mini access kit or that micropuncture set here. And so this is a very, very small patient. This is a 2 kilogram dog that actually had an intrahepatic shunt, so a pretty unusual situation. But a small access there. So again, using our 22 gauge to get access into the jugular vein. We weren't even sure we were quite in at that point because it's such a low pressure there. We get our 018 guide wire in to allow us to maintain access. Micropuncture set again. Going to take that catheter off, use this transition dilator just to get us large enough so that we can actually get a bigger wire in there. So we're going to work our way in with that dilator and that holding position there. Take out the wire and the dilator, and then you can immediately go in with your larger wire. And so again, the small dog, small jugular vein, but you have to get a big sheath in there in order to be able to do this procedure. This is taking that transition dilator off and then coming in here with a 9 French sheath. So small dogs, because the stent that you place is smaller, you can place a smaller sheath in those cases. So you still have to get a 9 French sheath though and do a 2 kg dog. So that can be a challenge. 9 French in this situation would probably be about a 3 to 4 millimeter hole in a small dog jugular vein. So it can be challenging. Like I said, natural orifice, we use that as another approach whenever possible. The mouth for tracheal and esophageal stents, going through the anus for colonic stents, the penis or vulva for urethral and ureteral stents. Percutaneous, and so most commonly when we're doing percutaneous access is to place ureteral stents for malignancy, and so we'll usually go into the renal pelvis, and I'll show an example of that here in a minute. We also place our drains and things like that for abdominal and thoracic cavity drainage, drainage tubes for cystostomy and cholecystostomy. So here's a percutaneous ureteral stenting example, and I'll just kind of run through it on this little PowerPoint animation. We use ultrasound to identify the kidney. If we're placing this for a percutaneous malignant ureteral stent, it's because, sorry, this kidney looks crazy, it looks blue, but I guess it's angry because it's obstructed, but it's, we're placing that these kidneys, these renal pelvis are nice and dilated, so they're big, so you can see them with ultrasound. And so you're seeing them percutaneously, you're ultrasounding them, you see this big dilated renal pelvis, and so you're getting access with ultrasound to get an IV catheter in position. Once that catheter is in position, you can then place a guide wire down through that. So here's what we're looking at here as an example. So heads off to the right, tails off to the left. Here is our IV catheter that's been placed ultrasound guided into the renal pelvis. You can see it better on the image on the right. And so on this image on the right, make sure the arrow is showing up. Yeah, image on the right, here's our catheter coming in, and then we've hooked up a T-port to that, and we have contrast that we're delivering. And so as we're injecting contrast, you're seeing the renal pelvis enhance, and then you're seeing the ureter enhance. And so you're seeing it's a nephroureterogram, nephropyelogram, ureterogram. And so essentially as you're doing that injection, here's that injection, we're injecting into it, this is going the other direction, but you're injecting, you're seeing the renal pelvis, and you're seeing this ureter, big dilated ureter, very tortuous because it's obstructed. It's pretty common that we see that. And then when it gets down to the bladder, you can see that it's struggling to get contrast into the bladder. Essentially what's happening here is you have a ureteral obstruction at the level of the ureterovesicular junction. So it's a tumor in the typical location where we'd expect it to be. It's at the trigone, and it's growing up over the trigone, covering the ureterovesicular junction. And at that point then, the contrast is just barely getting through. And so I'll show here with the arrow so everyone can see. Essentially at this point here, you can see just a little bit of contrast sneaking through into the bladder. So this is our bladder here, and so this is the only urine or injection that's able to get through. And you're also giving this under pressure, so you can see why these ureters would be obstructed. If you're giving pressure and you're injecting this, you're able to bypass some of that obstruction. But in a typical case where they only have ureteral peristalsis to actually push urine through, it's not enough to actually get urine through, and so that's why they're obstructing. So we're getting just a little bit to go through, but at least at this point we know that there's a slight opening between the kidney and into the bladder. And so that's going to be what your target is for getting your wire down. So we've done our nephroureterogram. Now we know where the kidney pelvis is. We know where the ureter is. So now with fluoroscopic guidance, we're going to try to direct a wire down and get it into the bladder, because your goal is to try to place a ureteral stent percutaneously. Also do this for thoracic drain placement. And so lots of different ways to do this. This is just an example of placing one after a small stab incision. So we're just doing a stab incision at the location where we want this to actually sit. This is a cadaver, so you're not going to see any bleeding. But this is using a locking loop pigtail catheter. And so it has an inner stylet as well as a needle, so you can use the needle to actually puncture. The stylet will stiffen it, so once you get access directly into the chest cavity, you're going to take the needle out so that you don't accidentally hit the needle onto anything intrathoracically. And then you can pass the catheter up over top. But just another example of an approach, of a way to get into a location that we historically might have had to make more of a big surgical approach to, but you can use this instrumentation to get you into them. Excuse me. And then lastly, a cystostomy tube placement. And so this would be an example of percutaneously getting access into a bladder. And so we have a needle now currently stuck into the bladder. We're coming in laterally. So again, we've gained nice access into the bladder. We're doing this all through just a stab incision, so keeping it minimally invasive. We've taken out the needle, left the IV catheter within the bladder, passing the guide wire through that catheter, and now we can actually pass a locking loop catheter up over top of that. And so if you look close, this darker part is the catheter. It's been placed over the guide wire, so all this is percutaneous again. So it lets us keep everything just down to a small stab incision. Now you have your catheter in your bladder, and you can use this as a cystostomy tube or as a temporary way to drain urine in these situations where you want to try to keep it minimally invasive, but also you have to be able to provide them with urine drainage because they have some sort of urethral blockage. All right, so just to summarize where we are, I'm not going to cover every single application, but the major ones, the major non-neoplastic obstructions we see, tracheal collapse, urethral obstructions by far are the most prominent types of obstructions we see. Esophageal, ureteral, very common. Ureteral is actually really common as well. So we do see those in our cats most commonly, but also in some dogs. Neoplastic, there's a lot of different applications here. Basically, if there's a lumen and it gets a tumor in it, you can attempt stenting it, and so we could talk about that kind of stuff all day. We'll look at a few of these throughout the day today. Non-neoplastic vascular applications, most commonly it's looking at shunts. We do see intravascular foreign bodies. This is an example of an intravascular foreign body. It was an IV catheter that got accidentally cut when they were removing it, so just came across the actual catheter bit and that launched up into the pulmonary artery. And so you can go in. This is an example of a gooseneck snare. And so we went in basically, as you pull the gooseneck snare back into its catheter, you can compress it down and then bend it and pull it out that way, so it's a nice option. Neoplastic vascular, this is where a lot of the major expansion has happened in the last 5 years, looking at embolization, so treating these different tumors, liver, nasal, prostate most commonly, but you can treat tumors anywhere, and intraarterial chemotherapy, so giving chemotherapy directly to a tumor. And then lots of miscellaneous applications, drainages, intracavitary treatments, and ablations. That just gives you a kind of a quick overview of the veterinary applications, but as an intro, hopefully that kind of leads into a lot of these different procedures today that we'll talk about. And then, so I'll use a lot of these terms kind of throughout the day, but let me know if anything's not making sense, and happy to start with any questions anybody has on that. Excellent. All right. Well, I see a coffee break built in already. So I don't know if we want to we'll stick to the schedule, maybe do that. Coffee break. That's good. Yeah.